Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. The United States is falling behind other high-income countries when it comes to life expectancy. A new report finds that people in the UK are living nearly 3 years longer than those born in the US, a gap that keeps widening. The reasons may surprise you. Today, Stephanie Desmond talks to co-host Dr. Josh Sharfstein, who led the report from the Bloomberg American Health Initiative. Let's listen.
Josh Sharfstein, thanks for joining me.
Stephanie Desmond, great to see you.
It's always nice to talk to my co-host. One of the many jobs that you have is leading the Bloomberg American Health Initiative. And recently, you put out a new report on life expectancy, comparing the United States to England, and you found something really interesting.
So the Bloomberg American Health Initiative is this big project that we run out of the School of Public Health that's focused on improving health in the United States and thinking about some very important causes of suffering and premature death affecting so many people around the country, from addiction to violence and on and on. And what we did as part of this report was ask a pretty simple question. Why are Americans dying so much earlier than people in the United Kingdom, including England? And is there anything that we can do about it?
And what did you find?
Well, we found that 40 years ago, a baby born in the United States and a baby born in the United Kingdom had about the same life expectancy. But over time, that's really grown. And now it's almost 3 years of difference, people dying earlier on our side of the Atlantic. And the entire gap, the entire reason for this difference is related to preventable illness. And we looked in this report, there are a number of faculty members who worked on it, at which preventable illnesses and injuries were causing that gap and what could be done about them.
So there was a really stark difference in the world of cardiovascular disease. Talk about that.
So cardiovascular disease alone accounts for 57% of the gap between the United States and the United Kingdom. We were able to look at data for England and Wales, which is about 90% of the United Kingdom. And 57% of that 2.7-year gap is related to cardiovascular disease, heart disease, diabetes, stroke, and that whole set of serious illnesses. And those are, to a large extent, preventable. And what we see is that people in the United States have more risk factors and many times less access to care. And you put those things together and you get much more death. We can reverse those things, reduce those risk factors, and give more access to care, and we can close that gap.
It's surprising to me that the gap is so big in terms of cardiovascular disease. I guess it's a matter of our food, our physical activity levels. I mean, why are we so much less healthy?
Well, there are a lot of interesting reasons. We know that the U.S. has a lower quality diet, less physical activity, more obesity, more hypertension, a greater intake of sodium, which is linked to hypertension, and more diabetes. And all of those contribute to cardiovascular disease. We also don't have a healthcare system that's really organized around prevention and giving people the care they need to stay healthy. So you put all those things together, more risk factors, less access to the kind of care that prevents problems, and you get more preventable problems and a 57% contribution to the gap in life expectancy.
So also a large factor is opioid use. Talk to me about that and why things are different in the US versus the UK.
Sure. Opioid overdose and drug overdose in general is the number 2 contributor to the cause. It's 32% of the gap between the United States and England and Wales. The rate of drug overdose in the United States, I believe, is more than 3 times the rate in England and Wales. That is just an enormous difference. There are a number of reasons for that, but one of the major ones is that there is more access to care for addiction in the United Kingdom, particularly in places where people who are at very high risk for overdose go. One example of that is jails and prisons. And so faculty who work in this area pointed out that if we can make medications for opioid use disorder more available and treatment programs more accessible, particularly for people in the criminal justice system, we can take a big step towards closing that gap.
So in the UK, they're doing a better job treating inmates?
They are, yep. And it is, in general, they have the same healthcare standards for incarcerated populations as they do for the general population. And although there are gaps in both, overall, people who are incarcerated get more addiction treatment than in this country. And one of the things they've been able to show is that that's not just good for preventing overdoses, but it's good for preventing crime. When people have an addiction, oftentimes they're committing crimes to get the money to support that addiction. If you treat the addiction, particularly when people are incarcerated or in probation, then they're less likely to go out and cause harm to their community. So it's just a really important intervention, both for community safety and for public health.
Is there a lack of political will here to do that?
Well, I think things are slowly moving in the right direction here, but they could be accelerated. It's interesting. We have a very complicated criminal justice system. In many of the key institutions, and we're talking about jails and prisons, are run at the county level. And so there are just so many individual decisions being made. It's not like someone could flip a switch and say, well, of course this makes sense. Let's treat everyone. You have to be able to have the capacity to treat people. You need the legal framework to treat people. You need the resources to treat people. And slowly those things are falling into place. There have been some court decisions requiring treatment in some cases. There was a really important rule that came out of the HHS, the Substance Abuse and Mental Health Services Administration, that gives more flexibility for treating people in jails and prisons. So you see that happening at Johns Hopkins. We have a whole team that works with jails and prisons across the country to improve access to treatment, but this could really be accelerated.
And then this one does not surprise me at all, which is guns. Talk me through that.
Sure. Gun-related homicide and suicide accounts for 20% of the gap between the United States and the United Kingdom, focusing on England and Wales. And it is, an enormous difference. Just to give you a sense, the age-adjusted death rate from firearm-related homicide and suicide is about 13.3 deaths per 100,000 in the United States. In England and Wales, it's 0.1.
Wow.
There are only 90 individuals who died from firearm-related causes in 2023 in those two areas of the United Kingdom. And in the United States, it was 45,000. Now, we have more people. We don't have that many more people. I mean, that's just an enormous, enormous difference. And when you even go down to a very particular issue like teen suicide, which is just an unimaginable tragedy every time it happens, the rate in the United States is about 10 per 100,000 compared to less than 6 in England and Wales. Half of our suicides are related to firearms in that age group. So that big difference, firearms really can account for the whole thing. So it's really an enormous public health problem that we have on our side of the Atlantic that they really don't have. Now, I should say that the United Kingdom has some very, very strict gun laws that I think unquestionably would be unconstitutional in this country, given that we have the Second Amendment. But when we consulted with experts for this report, they pointed out that there are some absolutely constitutional approaches that have been demonstrated to reduce gun-related homicides and suicides in the United States that are implemented in some parts of the country that could be scaled up and would save a lot more lives here.
Such as?
So one of them is licensing laws, where people have to actually get a license for a gun, like you kind of have to get a license to drive a car. The second is the extreme risk protection orders, sometimes called red flag laws, which allow a family member, for example, to call attention to someone and have guns temporarily removed by a judge on the basis of risk at the moment. And those laws are estimated for, every 10 or so orders that are given to temporarily remove guns, they prevent a suicide. So there are all kinds of checks and balances there, but they really act in response to risk and reduce the use of guns in these fatal events.
And then car crashes make up a decent size of part of this gap.
Yeah, I can't say that I would have predicted that, before this analysis was done by Dr. Jamil, one of the demographers here at the school. We found that car crashes represent 17% of the gap. And the rate of fatal car crashes in the United States is 6 times the rate of fatal car crashes in England and Wales. And that is, a high number. It's out of proportion even to the differences in the degree of rurality and other factors that I think are associated with car crashes. And it turns out that the United Kingdom has some pretty interesting policies in place. And they really focus on reducing fatal car crashes. And, one of the things is that these used to be called accidents, like it was a motor vehicle accident. But the way public health thinks about it is that it's not just a random event that somebody gets hurt. It's related to an underlying cause, and those are related to policies. So even if a particular crash, you couldn't have predicted that particular crash, you can predict that if certain types of policies are not in effect, you'll have more crashes. And so something can be preventable and random. And when that happens, it's not an accident. It's actually something that we should be working together to try to avoid. The 3 items that one of our faculty, Dr. Azani, pointed out in his suggestions that are in the report include intelligent speed adaptation, advanced impaired driving technology, and hazard perception testing, which are different aspects of road safety policy that exist in the United Kingdom. And he estimated that the United States could reduce motor vehicle crashes by nearly half, saving 18,000 lives a year by adopting them here. So we have within our reach, there's a lot of talk about making America healthy. The way to close the gap between the United States and other countries is by following the evidence and preventing conditions that are happening in this country that are not happening nearly as frequently in other places.
So how do we do that?
Well, it's really important for people to realize we have a problem. And, I think it's good that people are talking more about the problem of health in this country. And then we have to recognize that we don't have to start with a completely blank sheet of paper, that there are approaches that have worked in other places and are within our reach. In many places are being implemented in parts of this country. And if we can focus on solutions that will work, we will have success. And we have had success. There are success stories along the way, and we can have a success at a much broader level for the United States if we can follow the evidence.
If you could wave your magic wand and change one thing right away, what do you think would be key?
To me, and this is going to be the broadest public health answer, it is that we make a national goal to improve life expectancy, to catch up to other nations, to reduce the disparities and inequities that exist in life expectancy, and to monitor our progress and use data to implement solutions to achieve that goal, because we can do it. And with that one commitment, I think a lot of the different solutions can fall into place.
What's unique about the United States, do you think, that makes these factors so real?
That might be a much longer podcast to talk about. Maybe this will be podcast 1 with Josh and Stephanie of 512, and we can explore the different reasons. I would just say that we have some great aspects of health policy in the United States and others that have lagged other countries, and our policymaking processes, the way that things are decentralized. It's often hard to have coordinated strategies like the ones that I might dream about. But at times, the stars have aligned and we have done it. And I think that we can do it again in these areas.
Josh Sharfstein, thanks so much for joining me.
Thanks, Stephanie.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Fernandez-Cesiri. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Social media run by Grace Fernandez-Cesiri. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.